When we talk about parasympathomimetics, first of all, it is important to revise that how parasympathetic system acts. So parasympathetic acts basically by the release of acetylcholine. So we should know that what are the receptors for acetylcholine and how and where this action is brought about. So the receptors are two types, nicotinic and muscarinic. Okay. Nicotinic receptors are broadly classified as N type and NM type, and muscarinic are of 5 types, which include M1, M2, M3, M4 and M5. So these nicotinic receptors, where are they present? N type, they are present in the ganglia. Ganglia means the presynaptic neuron, where it makes contact with the postsynaptic neuron. The postsynaptic neuron is having this NN receptor. So even the sympathetic neurons, the preganglionic neurons of the sympathetic system, they contact the contact which they make with the postganglionic neurons. There also acetylcholine is released and it acts via NN receptors. Then NM receptors, they are present in the neuromuscular junction. Okay, so this is the muscle. NM receptors are present at the motor end plate. So nicotinic 2 receptors, NN receptors present at the ganglia, and M receptors present at the neuromuscular junction. Then coming to muscarinic receptors, I told you there are 5 types, M1, M2, M3, M4 and M5. So in this, M1 receptor is present in the stomach, that is for acid secretion, okay, and also in the brain, very important, because in brain this M1 receptor is present in the hippocampus, where it is important for memory consolidation, and also acetylcholine is released throughout the cortex, where it acts for the initiation of the REM sleep. So this acetylcholine receptors, M1 receptors, are present in the cortex and the thalamus and are responsible for the initiation of REM sleep. For the video on mechanism of generation of sleep, I have already made one video, you can watch that. There I have told that how in REM sleep the concentration of acetylcholine is very high. Okay, coming to M2 receptors, they are present in the heart, okay, and they are also present in the presynaptic neurons, right? So here when there is junction between the two neurons, they will be present here on the presynaptic neuron, and they will modulate the release of acetylcholine. So this is important to learn, because in the next video when we will talk about parasympatholytics or anti-parasympathetic drugs, there we will discuss that how atropine acts on these receptors as well. Anyway, so simple to remember, M2 is present on the heart and on the presynaptic neurons. In the heart, M2 is responsible for decreasing the heart rate and decreasing the conductivity. Sympathetic system increases heart rate, increases conductivity and increases the contractility. Parasympathetic decreases heart rate, decreases conductivity, hardly any effect on contractility. Okay, atria some effect is there, ventricle no effect, right? Then M3 receptors, they are present in smooth muscles and glands, and here they are present in smooth muscles throughout the body. So we will see the functions in each of the smooth muscle one by one. So first is eyes, and in eyes they are present in 2 regions. One is sphincter pupillae and the other is in ciliary muscle. Sphincter pupillae, as the name suggests, sphincter, okay, it is a sphincter. So what it will do that say suppose this is the eye and here we have the sphincter pupillae. This parasympathetic stimulation will cause the contraction of this sphincter muscle, and this will lead to the constriction of the pupil. Okay, so the pupil will decrease in size. Sphincter pupillae contraction will cause the constriction of the pupil. Then ciliary muscle, that is important for accommodation. Okay, so there is change in diameter of the lens, so that is responsible for near vision. Okay, ciliary muscle contraction also occurs. Then GIT, there is a muscle contraction, it increases the GI motility, and also there is sphincter relaxation. Urinary bladder also similar, there is contraction of the detrusor muscle and there is relaxation of the sphincter. Bronchus also, there is bronchoconstriction. Then important one, that glands, the parasympathetic activity increases the secretion of almost all glands of the body. There is increased secretion of the lacrimal glands, salivary glands, then digestive glands. There will be increase in the secretion of the digestive enzymes, okay, and tracheobronchial secretions also increase. So that is parasympathetic. Okay, so in bronchus, what will be the effect? There will be bronchoconstriction and increase in the tracheobronchial secretion. Then in blood vessels also we have receptor, that is M3 receptor. However, remember, in the blood vessel there is no direct neural supply to the blood vessels, but there are these M3 receptors, and acetylcholine, suppose the external agents which are mimicking the acetylcholine, if they are released, this can bind with these M3 receptors, and M3 receptor stimulation will cause the release of nitric oxide, and this will lead to vasodilation. Neural, there is no action, but there are still receptor present which can cause vasodilation by release of the nitric oxide. Now, one concept you remember that all these muscarinic receptors are blocked by atropine. Okay, so more about atropine we'll see in next video. Then, what are these parasympathomimetics? Let us move on to the classification of parasympathomimetics. So, we have directly acting parasympathomimetics and indirectly acting parasympathomimetics. So, if I draw like that, that parasympathomimetics means I want increased action which is similar to that of acetylcholine. Okay, so I want increased parasympathetic action. For that, I can give some substance which directly mimics this acetylcholine. Okay, so anything which mimics acetylcholine and binds directly to its receptors and causes the action, or I can give anti-acetylcholinesterase. Acetylcholinesterase is the enzyme which breaks down acetylcholine to choline plus acetate. Okay, so if I give something which is inhibiting this acetylcholinesterase is inhibited. If we inhibit this, then there will be more accumulation of acetylcholine, right? So hence we will get parasympathomimetic effect. So the drugs which mimic acetylcholine, they are known as directly acting, and the drugs which inhibit acetylcholinesterase enzyme, inhibit the breakdown of acetylcholine, they are known as indirectly acting. In the drugs which are directly acting, further classification is there. These are natural or also known as alkaloids, and there are synthetic drugs. Okay, so in the natural ones we have erecholine, okay, muscarine and pilocarpine. Most important one among this is the pilocarpine. We will see each of these drugs one by one again later. Okay, so you can simply remember it as PAM. PAM is the drugs for this. Okay, PAM. That is pilocarpine, erecholine and muscarine. Pilocarpine I have written in the P, I have written in the top because it is the most important, pilocarpine. Then synthetic we have. Synthetic include methacholine, bethanocol, carbachol. Acetylcholine is also there, not used much clinically because when injected, even IV when it is given, it is rapidly broken down. Okay, so not much effect is there. However, we will see one clinical action as well. Okay, so we have methacholine, bethanocol, carbachol. You can remember this col is for choline. Okay, bethanocol, carbachol and acetylcholine. So these are the esters and these are the synthetic drugs. Then we have indirectly acting. Indirectly acting, again we have two types, that is reversible and irreversible. In reversible we have tertiary amines and quaternary amines. That means tertiary amines means that they are like this, okay, and quaternary amines means they have NH4 positive. Okay, so because of this ion, quaternary amines cannot cross the blood-brain barrier, cannot cross lipid membrane. Okay, so they cannot cross the blood-brain barrier, they cannot cross the cornea. Tertiary amine on the other hand, they can cross the cornea, they can cross the blood-brain barrier. So we will see that these drugs are utilized in such conditions where they need to cross the barrier. Okay, on the other hand, quaternary amines, they are the ones which will not cross the barrier. Tertiary amines include physostigmine, tacrine, donazepam, rivastigmine and galantamine. 5 drugs you have to remember. Quaternary amine include neostigmine, pyridostigmine and edrophonium. And this you can remember by a mnemonic We'll see later also, because these drugs are used in myasthenia gravis, so men P, and here they are arranged in the duration of action. Edrophonium is the shortest acting, N-neostigmine a little longer acting, and pyridostigmine is the longest acting. Now confusion may arise between this pyridostigmine and physostigmine, because physostigmine comes in tertiary amine while pyridostigmine is a quaternary amine, so sometimes you may get confused. So simple, you remember physostigmine, so it is coming, physo is slippery, okay, slippery means it can cross the lipid barrier, okay, so that is physostigmine. Then irreversible acetylcholinesterase inhibitors, they are not used clinically, remember, however they can cause poisoning. Irreversible inhibitors means that they bind to the acetylcholinesterase irreversibly. So for the reaction of the enzyme, we need new synthesis of the enzyme. Till the new enzyme is synthesized, these enzymes will remain inhibited, okay. So till that time acetylcholine levels will be high. Reversible means it is short acting and then it will dissociate also, right? It is not like it is completely, it is attached to it. It dissociates, binds, and it is short acting. Irreversible, it forms a covalent bond with this acetylcholinesterase enzyme, okay. So for that we needed resynthesis of the enzyme, and then only there will be action of acetylcholinesterase. So these organophosphates and carbamates which form covalent bond with acetylcholinesterase, they form the irreversible, okay. So quickly we will revise what are the parasympathomimetics we have read. We have read about directly acting and indirectly acting. Indirectly acting we have two types, natural and synthetic. And in indirectly acting, again we have reversible, irreversible. Irreversible are not clinically used, therefore they will cause the poisoning and we have to treat them. And the reversible ones, we have tertiary amines and the quaternary amines. Tertiary amines will cross the blood-brain barrier, while quaternary amines will not be able to cross the blood-brain barrier and also the cornea, okay. Now coming to these drugs one by one. What are these drugs? So we will talk about directly acting drugs. So first drug is the directly acting drugs, the natural ones, that is the alkaloid ones, okay. So here muscarine, erecholine and pilocarpine is shown. You see I have not given any use of muscarine and erecholine because they are not used clinically. However, this muscarine is present in certain mushrooms, okay, and it may lead to mushroom poisoning. So there are certain species of the mushroom, inocybe and clitocybe, and that can lead to increase in the muscarinic action because of this muscarine which is present. So if that is there, what will happen? Basically this poisoning will lead to all the effects which are similar to that of the action of increased acetylcholine. So we have already seen what are the actions of acetylcholine. So what it will do? Increase salivation, increase lacrimation, bronchus, there will be bronchospasm, intestine, it will contract, so there will be intestinal colic, visual disturbance because there will be meiosis, there is accommodation, okay, too much contraction will occur, so both will lead to visual disturbance. Then also effect on the heart, there is bradycardia, that is decrease in the heart rate. Then decrease in BP, why it will occur? I told you that if it mimics the action, then it is going to bind to the receptors, M3 receptors, there will be release of nitric oxide which will lead to vasodilation. So that can lead to decrease in blood pressure. Obviously bradycardia will also contribute to decrease in blood pressure and ultimately it will cause shock, okay. So this we have to remember. Okay, how you will treat such kind of poisoning if there is increase in acetylcholine action? Well, we have to give a drug which opposes this action, and that is atropine. I told you before, atropine is a drug which blocks the action of all the muscarinic receptors, okay. So that is the importance of this muscarine. Then coming to other drugs, that is erecholine, I have not mentioned anything. Then coming to pilocarpine. Pilocarpine is a drug of choice for closed angle glaucoma, okay, and here it acts because of its parasympathomimetic action. How and all we will discuss in another video on glaucoma drugs, okay. So we use parasympathomimetics or adrenergic blockers for glaucoma drugs, that we will see later. Then it can also be used for the treatment of xerostomia. Xerostomia means dry mouth, okay. Dry mouth basically there is decrease in salivation, and that can occur due to radiation, or there may be Sjogren's syndrome, autoimmune destruction of the salivary glands is there. So in that case there will be xerostomia, decrease in the formation of the saliva. So we can use pilocarpine because of its parasympathomimetic action. It will cause increase in the salivation of whatever it's left, it will cause increase in the salivation. Okay. Then some important points of pilocarpine is that it has very short duration of action. So when we are giving it for glaucoma, we have to remember that even if single dose is missed, then it can cause increase in the intraocular pressure. This is IOT. Okay, so there is increase in the intraocular pressure even if one dose is missed. Then one of the important side effects of pilocarpine is that it causes marked sweating. Diaphoresis means sweating. It causes marked sweating. Approximately 2 to 3 liters of sweating can occur. Plus, I am telling that it is drug of choice for closed angle glaucoma, but you have to remember that not to be given in asthmatics. That is true for all the parasympathomimetics. Why? Because acetylcholine is causing bronchospasm, isn't it? So if bronchospasm is occurring, asthmatics are more prone, because asthma, there is narrowing of the bronchus, there is bronchospasm. Okay, so we should not give parasympathomimetics to asthmatics. Then comes next drug, bethanocol. Okay, so now we have covered the naturally occurring directly acting drugs. Then these 4 are the esters, okay, synthesized drugs. Bethanocol and carbachol, they are mainly used for non-obstructive urinary retention. Non-obstructive, right? If there is obstruction, and if you give a drug which causes contraction of the urinary bladder, then urine will not flow out. Instead, it will lead to excessive pain. So we have to make sure that it is non-obstructive urinary retention. Bethanocol can be given. Okay, so B for bladder, right? Then it can also be used for hypotonic bladder. Hypotonic bladder is like overflow incontinence, neurogenic bladder, where the bladder is not contracting properly. Okay, so that also it can be given. So in some conditions where spinal cord injuries occur, in that cases the bladder will behave like this. So in that cases also bethanocol can be given. Then it can also be given for post-operative abdominal distension. So mainly for its effects on GIT and bladder, bethanocol is being used. Okay, post-operative abdominal distension. So basically we can say that this bethanocol and carbachol are mainly M3 selective. Okay, M3 selective because it is acting on the smooth muscles, and the cardiac action is very less. Okay, so M2 action is not there. So good for the treatment, isn't it? We will not get bradycardia as the side effect. Okay, so we have bethanocol and carbachol which are M3 selective, right? Then we have methacholine. Methacholine can be used for methacholine challenge test for airway hyperreactivity. Okay, we know that parasympathomimetic action is causing bronchospasm. To check for the sensitivity of the bronchial constriction, we can give this methacholine challenge test. Okay, but we have to remember that this methacholine is non-selective and it has M2 dominant action. Okay, so this will cause bradycardia also. So non-selective means that only. Methacholine challenge test we are using based on M3 receptors. M3 receptors are present in bronchus, but it also has M2 dominant action. Okay, so methacholine is non-selective, bethanocol and carbachol are M3 selective. And finally we have acetylcholine. Yes, I told you that generally it is not used clinically, but it can be used as ophthalmic surgical aid because during the surgery it can cause rapid meiosis. Okay, but otherwise it is not used directly because it is very easily metabolized in plasma. Moving on to the indirectly acting parasympathomimetics, that is, we are talking about acetylcholinesterase inhibitors. Okay. So first we will discuss about the reversible ones which are used clinically. In reversible one, we said that there are 2 types, tertiary amines and the quaternary amines. Tertiary amines can cross the blood-brain barrier and cornea. So we have 5 drugs in that: physostigmine, tacrine, donepezil, rivastigmine and galantamine. So physostigmine is important. Physostigmine is the drug of choice for atropine poisoning. See, atropine, what it is doing? Atropine is countering the effect of acetylcholine, right? So if atropine is too much, we won't get any parasympathetic action. So to counter that, physostigmine is given. It is the drug of choice for atropine, or also known as belladonna poisoning. And it can also be used in glaucoma. I told you that it can cross the cornea, it can cross the blood-brain barrier, lipid soluble. So it can also be given in the closed angle glaucoma, which we discussed. What was the other drug? Pilocarpine, okay, PP, pilocarpine, physostigmine, can be given in the glaucoma. Then other drugs, that is tacrin, donepezil, rivastigmine, galantamine, they are used in Alzheimer's. Only thing is that this tacrin, now it is not used because of reports of hepatotoxicity. Okay, so now it is not used. But the drug of choice for Alzheimer's is donepezil. Okay, why it is used in Alzheimer's? See, I told you that acetylcholine, lot of acetylcholine is released in the cortex also, and there is presence of acetylcholine receptors, M1 receptors in hippocampus. And Alzheimer's, what is the main problem? Problem is loss of these cholinergic neurons, and there is loss of this memory because of that. Okay, so we can use parasympathomimetics, and the drug of choice is donepezil. Other drugs also can be used, that is rivastigmine and galantamine. Then moving on to quaternary amines, that is the ones which cannot cross the blood-brain barrier. In that we have three, I told you before. Men-P, men because M, because M for myasthenia gravis, then ENP, E for edrophonium, N for neostigmine, P for pyridostigmine. Okay, edrophonium is the shortest acting and pyridostigmine is the longest acting, so it is arranged like this. Edrophonium is used for the diagnosis of myasthenia gravis and for differentiation between the myasthenic versus cholinergic crisis. When edrophonium is given, because it is a blocker of acetylcholinesterase, it will increase acetylcholine levels, right? So myasthenic condition, if it is a myasthenic condition, then it will improve. Okay, so that is edrophonium and how it is used for diagnosis of myasthenia gravis. And why it is used? Because it is very short acting. It acts for only 10 to 30 minutes. Okay. Then neostigmine and pyridostigmines are the drugs which can be used for myasthenia gravis. They can be used for the treatment of cobra bite. Okay. Cobra venom has a neuromuscular blocker. Okay. So sometimes, not all, but there may be presence of neuromuscular blocker in cobra venom which will cause the paralysis. So for reversal of that, neostigmine and pyridostigmine can be used. Then neostigmine and pyridostigmine are also used for reversal of muscle relaxants. See, what are muscle relaxants? Muscle relaxants are neuromuscular blockers, NM blockers. Okay, so by giving neostigmine and pyridostigmine, what happens that acetylcholinesterase is inhibited. There will be increase in concentration of acetylcholine locally. Okay, so there will be competition between the blocker and acetylcholine. Already because of the neuromuscular blocker, depending on which blocker is used, there will be competition. So this acetylcholine, increased acetylcholine, now can bind to its receptors. Okay, so what are the uses of neostigmine and pyridostigmine? Myasthenia gravis, cobra bite, and reversal of muscle relaxants, right? And one point you remember here that when we are using neostigmine and pyridostigmine, see, all these uses depend on its action on the NM receptor. Okay, because that is at the level of the neuromuscular junction. So we should add atropine along with this so that all the muscarinic effects are blocked. Okay, so add atropine with the neostigmine so that we do not get muscarinic effects. And another point you should remember here that neostigmine, apart from inhibiting acetylcholinesterase enzyme, it also directly stimulates NM receptors. Okay, directly stimulates NM receptors also. So two mechanism of action for neostigmine: direct stimulation of NM receptor and also acetylcholinesterase inhibition. So we can say that it is both directly as well as indirectly acting. Predominant action being the inhibition of acetylcholinesterase. Now, moving on to the next important part, that what are the contraindications for use of muscarinic agonist? I told you before, one is asthma, because muscarinic agonists are going to cause bronchoconstriction. Okay, so they should not be used. Hyperthyroidism, because of the effect of parasympathomimetic on the heart. Hyperthyroidism patients may develop atrial fibrillation. Okay, then these parasympathomimetics should not be used if there is presence of coronary block, coronary insufficiency, that is decrease in coronary blood flow, because there are chances that they will cause hypotension, isn't it? We said that acetylcholine can act on the M3 receptors on the blood vessels, so these parasympathomimetics also can act on the blood vessels. There will be increased release of nitric oxide and there will be hypotension. So we should not give that, because hypotension which occurs can decrease the coronary blood flow. Then they should not be used in peptic ulcer, acid peptic disease, because they are causing increase in secretion of all the secretions of the body, right? So gastric secretion is also going to increase. So these 4 contraindications you should remember: asthma, hyperthyroidism, coronary insufficiency and peptic ulcer, right? Finally, just we will finish by the discussion on indirectly acting parasympathomimetics, which are irreversibly inhibiting the acetylcholinesterase enzyme. Okay, so we have in that organophosphates and there are carbamates. Organophosphates include malathion, parathion, nerve gas poisons are there, that is tabun, sarin, soman. Okay, nerve gas poisons used in warfare, ecothiopate. So these organophosphates irreversibly inhibit acetylcholinesterase, so they can cause poisoning. Okay, and these are the drugs malathion and parathion which are used as insecticides. So OP poisoning very commonly seen in farmers, right? And what will be the features? The features will be same like what we saw in the mushroom poisoning, that is due to increased action of acetylcholine. So there will be pinpoint pupils, intestinal colic, there will be bronchospasm, okay, increase in salivation, lacrimation. These all are features of organophosphate poisoning. Now, for treatment of organophosphate poisoning, what has to be given? Told you earlier also, we have to oppose the acetylcholine action, so we can give atropine. Also, we have to give other drugs, that is oximes, which will cause the reversal of the action of organophosphates. So basically, actually if we see acetylcholinesterase enzyme, it has 2 binding sites. One is the anionic site and the other is the esteric site. Now these organophosphates bind here in the esteric site and block this acetylcholinesterase enzyme. This oximes, what they do, they can bind to this anionic site and then cause the dissociation of this organophosphate from this esteric site. Okay, so these auxins can be used for the regeneration of the enzyme, regeneration of acetylcholinesterase. So atropine will block the excessive acetylcholine action, and auxins, they will cause the regeneration of acetylcholinesterase enzyme. Finally, we have carbamates poisoning, that will, those carbamates which irreversibly inhibit acetylcholinesterase. Now these carbamates bind to both these sites, esteric site as well as anionic site. So these sites are occupied. Okay, so what will be the treatment? Treatment will be atropine only, and in this carbamate poisoning we don't give auximes. Anyways, first of all, you see both the sites are occupied, so auximes will not be able to act, but they are actually contraindicated. Why? Because these auximes themselves have minor acetylcholinesterase inhibitory action. Okay, so they themselves have minor inhibitory action. So first of all, they cannot be used, the site itself is occupied, and if you give them, then whatever acetylcholinesterase is there, that will also be inhibited. So that is why auximes are contraindicated in this carbamates poisoning. Okay, so that was all about the cholinergic agonist. Thanks for watching the video. If you liked it, do press the like button, do share the video with others, and do subscribe to the channel Physiology Open. Thank you.